My name's Emma Suggett. I'm the Medicines Optimisation Lead for the West Midlands AHSN. I'm going to present to you a new initiative for community pharmacy called Transfer of Care Around Medicines. During the presentation, we'll tell you exactly what it is, but essentially it's improving communication between secondary care and the community pharmacist with follow-up from the community pharmacy. So the agenda for this evening is we're going to start with setting the scene around transfer of care around medicines, telling you what it's about and why we're doing it. We will then go on to a video from Pinnacle Health, who are the providers of Pharm Outcomes, which is the digital platform that we'll be using. We're then going to go on to a second video from the West Midlands LPN chair, who's going to talk to you about some of the benefits for community pharmacy contractors. After which we will have a brief section where I discuss evidence-based drivers and patient experience, followed by the provider's perspective, so what sort of steps the hospital pharmacy has had to make to put this in place for you. And finally, we'll have some closing remarks from your LPC chair.
Hello, I'm Jeff Blankley. I'm Chief Officer of Wolverhampton Local Pharmaceutical Committee, and I represent all of the community pharmacies in Wolverhampton, but I've worked closely with the other 3 Black Country local pharmaceutical committees specifically for this project, but I know this is going to extend to a footprint that's far bigger than just the Black Country 4. So there's approximately 1,300 community pharmacies in the West Midlands footprint. That includes Birmingham, Solihull, Black Country, Arden, Hereford and Worcester, and Staffordshire and Shropshire. The context for community pharmacy is that there are changes expected on how and what we deliver to patients, triggered by a variety of changes in the national landscape and NHS organisational structure. So community pharmacy had a new contractual framework announced in July, and there was a intent to move away from the supply function into delivery of more services, and TCAM is definitely in that arena, and I think that is definitely in the domain that community pharmacies can actually support patient care and improve outcomes and prevent readmissions when it comes to patients moving between the hospital and their home setting as a result of an intervention in hospital. So it's better utilisation of the pharmacy profession, recognising community pharmacy. It also starts to actually improve the collaboration and communication between the different parts of the pharmacy profession, whether that's hospital, whether it's the new PCN pharmacists and GPs, or whether it's community pharmacists. So that the opportunity to collaborate is really right now, and from the community pharmacist perspective, I think it's really important that we embrace this new piece of work and actually deliver for improved patient care and recognition for the community pharmacy profession. TCAM, which is around in many trusts already, is not around in this West Midlands footprint. So actually the Black Country is leading the way, and as a result of tonight's presentation, it will be spread out with the support of the West Midlands Academic Health Services Network. But actually it's coming from the work that the Black Country was funded initially through something called IPMO, which was integrating pharmacy and medicines optimisation into all STP pathways. So that's where we've started. We are confident of success, but it is required to deliver outcomes, and the ball starts to go into your court when it comes to delivering and registering the benefits to the patients that are discharged that are seen as high-risk patients, and the referral will come to you as a new piece of work.
So what exactly is the issue? We've developed a system in the UK whereby the mainstay of patient care is actually in the hospital setting. Pressures on the system are huge. Managers, doctors, nurses and pharmacists and even patients are all geared up to getting the patient at his home as quickly as possible, right from the moment the patient enters through the front door. It's not really, therefore, a surprise that this is an environment that's not conducive to supporting patients to take the medicines appropriately. Coupled with this, for most of their stay, patients are actually unwell and unlikely to be listening carefully to what often can be quite complex advice about their medicines. In reality, a significant number of patients actually leave hospital with little or no advice about their medicines, especially those who are discharged out of hours. To make matters worse, on returning home, many patients are greeted with numerous other bags of medicines, MDSs, loose strips of tablets, some of which are inappropriately stored. And we've all seen the obligatory ice cream boxes, which is used for storing medicines in most of patients' homes. So it's not therefore surprising that a lot of patients and carers become confused. And in reality, who they turn to is the community pharmacist, somebody who's easily accessible on their high street. But what is surprising is that currently, community pharmacists actually have no information about admission or discharge from hospital, and they equally have no information about the medicines on discharge from hospital. It's therefore not surprising some of the stats that we see on discharge from hospital. Some of the stats on these slides actually show how poor adherence is post-discharge. But I think what's most surprising is actually that collectively all these stats together amount to around 82% of patients experiencing some sort of issue with their medicines in the 2 weeks post-discharge. And that's really fundamentally why the transfer of care around medicines is a project that has now been nationally adopted across England. So, by way of introduction to our project, I just wanted to explain exactly what transfer of care around medicines was. It's about transferring information on discharge from secondary care to the community pharmacist, and then ensuring that those patients are actually followed up by the community pharmacist. So we would use a safe and secure digital platform to do so, and currently it's around 30% of trusts in England that have a transfer of care around medicines project in place. So outside the West Midlands there's quite a wealth of experience of transfer of care already. And in that it's over 90% of trusts who actually use a platform called Pharm Outcomes, which you may be familiar with.
So the following video is from Pinnacle Health. Our chosen electronic platform to transfer information is Pharm Outcomes, and as you all probably know, it's around 90% of community pharmacies have Pharm Outcomes in their pharmacies. So that's one of the main reasons that we've chosen Pharm Outcomes as our platform. But the following video is going to show you actually how to complete a referral.
Welcome to the Pharm Outcomes training video for PDS-enabled web-based hospital referrals. Sending referrals from the hospital pharmacy. To begin, log into Pharm Outcomes and click on the Services tab. To register a patient for referrals, click on TCAM registration on the left-hand side of this screen. Record that patient consent has been obtained. Enter the patient's date of birth, sex and family name to search PDS for the patient record. You can switch to search PDS using the patient's NHS number by clicking here. Click the green button to confirm that this is the correct patient record. If the patient record cannot be found on PDS, you can enter the details manually. You will need to type the name of the patient's GP practice here and select from the match that appears. Click Save to register the patient. Some hospital sites are sending admission notifications as well as discharge referrals. To send an admission notification straight away, click the quick link to Template 2 TCAM admission notification that appears in the green box. Start to type the patient name and select the record that appears below. If a patient has had multiple admissions, the most recent record appears at the bottom of the list. If no matching patient record appears, you can click here to return to the registration page. Enter the name of the patient's preferred community pharmacy here. You can search by pharmacy name, address, postcode or ODS code. You can search for an NHS pharmacy by clicking here, or use the map icon to search by location. Click Save to send the admission notification. You may also want to queue the discharge referral at this stage, but information for the discharge referral can be added at any time during the patient's stay in hospital. Use the quick link in the green box or click on TCAM Discharge Referral on the left-hand side of the screen. Start to type the patient name and select the record that appears below. Type the patient's hospital number here. To send the referral immediately, enter the name of the patient's preferred community pharmacy here. You can search by pharmacy name, address, postcode or ODS code. To enter the patient details but delay the referral until the patient is discharged, type Delay Referral into this box. Tick the appropriate recommendations and type any additional referral information here. Enter your name and contact number. If you use one preferred contact number, we can pre-populate this field. Click the orange button to attach a copy of the patient's discharge summary. Click Save to send or queue the referral. Discharge referrals which have been delayed for sending at a later date will be queued at the top of your services screen. This creates a work list of referrals that need to be sent as patients are discharged. To send a queued discharge notification, click on the saved record. You can display full patient details on this screen by ticking this box. Enter the name of the patient's preferred community pharmacy here and click Save to send the discharge referral. Managing referrals at the community pharmacy. Admission and discharge notifications will appear at the top of your services screen alongside any other referrals received. To acknowledge an admission notification, click on the service name. If this is not your patient, you can inform the hospital by entering a reason and clicking Return. To acknowledge the admission, click Complete Now. The patient information appears in this box. Once you have made a note of the patient information, tick this box and click Save. This will remove the admission notification from the referral section on your services screen. To action a discharge referral, click on the record. Enter your name into the practitioner name field and select from the match that appears. If you have not accessed the service before, you will need to complete the enrolment. Select a new practitioner, then Enrol Me. Type your full name and GPHC registration number. Confirm that you have met the requirements, then click Enrol. The patient information appears in this box. You will find a link to the discharge summary document in the referral details section. If you are unable to complete the discharge referral, select the reason from the drop-down box, type any notes here and click Return. This will remove the referral from your services screen. To complete the referral, click Complete Now. The follow-up date field will automatically populate with today's date, but you can change this if necessary. If the patient record was not verified with PDS, you will have the option to look up PDS by clicking this button. If the patient record is PDS verified, the link to SCR OneClick will become available on the right-hand side of the screen. Tick the boxes to record any support services you have provided to this patient. If the patient reports any side effects or adverse drug reactions, enter the relevant details in this section. If the first repeat prescription is available at the time of completing the referral, record whether or not it matches the information in the discharge summary. Record any issues by ticking these boxes. If GP action is necessary as a result of this follow-up review, for example, side effects require reporting or prescription repeat is incorrect, you must contact the GP practice. By clicking on the Yes box here, the information will also be transmitted by email if the practice has set up a preference for this. If they have not set preferences, the system will alert you of this at the point of GP practice selection. Use the Contact Information box to add details to populate the GP referral. Any additional consultation information can be recorded here. This will be visible in audit reports, so do not include any patient identifiable information. Click Save to save the record. This will remove the referral from the Referrals section of your services screen.
So during the video you might have heard a little bit about rejecting referrals, and I thought it was pertinent just to show you this piece of research that was published in the Journal of Pharmacy Management. It actually shows you the reasons why community pharmacies might reject a referral, and you can see really from the percentages of rejections that actually they're all legitimate reasons why community pharmacies have rejected the referrals. For example, the patient has been readmitted and transferred to hospital. The patient is now in a care home. You cannot contact the patient, so that might have been because the mobile phone number was incorrect on the referral and that sort of thing. So they're all legitimate reasons, and in all honesty, it's absolutely perfectly fine for you to reject a referral. If you reject a referral, the referral will go back to the referring hospital, and they'll be able to look and see whether they need to take any further action or not. So the next video shows benefits to community pharmacy contractors. It's presented and put together by Satyan Katecha, who's the West Midlands LPN chair. It's specifically put together by Satyan on the basis that he already has experience of TCAM. He owns 2 premises up in Leicestershire where transfer of care is already active.
Hi, my name's Satyan Katecha. I'm a community pharmacist. Many of you may know me as the local professional network chair for pharmacy for the West Midlands. I'm going to be talking to you about the transfer of care around medicine service, the TCAM module. And it's only certain areas of the country that have gone live, whereas in West Midlands we are just about to go live soon. So I have a pharmacy in Leicester which started receiving TCAM referrals a couple of months back. So what I'll be doing today is sharing with you some of the experiences of myself and a couple of members of the team as well, and hopefully a few other pharmacists in the area. So what is TCAM? Essentially, it means that when a patient of ours is discharged from hospital, we receive an electronic notification that the patient's been discharged with a TTO, so that's the to take home medicines, the discharge information. When it first started, this was originally launched around November time last year, so we had a launch event similar to the event that you have today. And then everything went quiet for 3 or 4 months. There was a couple of pilots with a number of pharmacies to see whether the transfer of the information was done accurately and it could be done properly, etc. But our pharmacy came on board quite by surprise. A couple of months ago, one of my staff was on Pharm Outcomes looking for a DMERS referral, and she said, there's something here called TCAM, I don't know what that means. So we clicked on it, and lo and behold, there was a discharge notification for one of our patients, which caught me quite by surprise. So I communicated with the LPC and with the LPN chair in Leicestershire, and I was advised that yes, we'd actually gone live, but this had happened almost sort of organically, it just happened. So we looked through the module, we looked at the different elements. So we had a couple of options when the referral came through. We could accept the referral, we could reject the referral, and then the final element was to complete the referral. So we worked our way through, and I would say I could say muddled our way through, but actually it was so intuitive, it's quite straightforward. So one of the biggest benefits that we found around the discharge information is that it takes out a lot of the guesswork in the pharmacy. So historically, we're a busy health centre pharmacy. We have about 10 doctors at any given time churning out prescriptions all day long. So we have to be efficient in the work that we do. And what TCAM has done is it's helped us plan our work around some of the most difficult patients that we have. Here we have one of our dispensers, Fazine. She's doing the MDS, which is probably one of the jobs in the pharmacy that everybody dreads. I'll ask her a couple of questions to see how it's made a difference to her work. So Fazine, how has receiving the discharge information made a difference to your work?
Well, it has helped us because it states how the patient is taking their medication. Also, it also gives us information on which medication has been stopped or started by the hospital. So it made our work a lot easier.
And would you say it's increased your workload, or has it reduced your workload, or is it about the same?
In actual fact, it has reduced. So we've got all the information that we need in this letter.
Okay, excellent. And would you, if anybody was starting TCAM or somebody doing blisters or something, would you say it's a positive or a negative?
Positive.
Brilliant. Okay. And can you give us an example? You had a discharge letter in your hand just a minute ago. Give us an example of some of the things that have changed as a result of that.
The timings. The patient was taking medication in the morning. Now it's changed to twice a day.
Excellent.
And a lot of medication have been stopped.
Brilliant. Thanks very much. Thanks, Fazine.
You're welcome.
Here we have Sona. She's one of our dispensers. So I'll ask Sona a couple of questions in terms of TCAM and how it's made a difference. So Sona, how has it made a difference to your work when it comes to receiving discharge information from the doctors, from the hospital?
It's made a big difference to our work because we can plan. Once we have a discharge letter, we know what we're working with.
Okay. And before you used to receive the discharge information, how would you know that a patient's gone into hospital?
Sometimes we get a phone call from the hospital to say the patient's gone in, or very rarely we get phone calls from patients themselves or the relatives.
Okay. And what about them coming out? So when they did come out of hospital, how much notice will they give you before
Very
the next?
last minute.
What do you mean by that?
Literally, they'd come out of hospital. They would have 2 weeks supply, but they'd tell us last minute.
And so
if
now,
you give us less than like 2 days or 1 day's notice.
and how has it changed now receiving the discharge letters?
It's helped us a lot because we can work proactively. Because we know they've had 2 weeks worth of medication, we can plan for those 2 weeks too. So we can see whether there's been any changes to their medication and it's been stopped or started. It just helps us because we can work ahead.
And does it help you in getting their repeats sorted out for the next prescription?
Yes, it does.
Okay, so if there was another pharmacy or another dispenser looking at TCAM or receiving that information, would you say it's a positive or a negative?
Positive for definite, yeah.
Okay, brilliant. Thank you very much. Thank you.
you.
Kirtan's our pre-reg, so he's responsible for reconciling and things. So I'll ask Kirtan a few questions around TCAM.
Sure.
So Kirtan, what's your role in receiving the information and with TCAM in general?
Normally, when we receive any TCAM, I look at the transfer of care letters, I compare them, I reconcile it with the current prescriptions. So I look at what the patient currently is on and what they've been taken in hospital, whether any changes have been made. I make a note of the changes and I'll advise the dispensers to be aware of these changes. If the changes have been missed out by the doctors, then I'll inform the doctor of any changes that need to be made.
Okay. And when does a pharmacist get involved?
The pharmacist gets involved when the doctor needs to be spoken to if there's any additional requirements required to the prescription, i.e. Any changes that need to be made, when the trays have been made to find out if certain medication is stable. Having this information in advance allows us to order any medication in advance, etc. Do any research as well in advance.
And from a learning perspective, because you're a pre-reg student or doing your pre-reg, how has receiving the transfer information helped you to learn better?
Receiving the transfer information has helped me to look at clinical information, look at why people are being brought into hospitals and see what the changes have been made afterwards. So it makes me aware of what changes should be I expect if patients are admitted for certain indications.
So here we're talking to Sarita, who's involved in downloading information from Pharm Outcomes. So Sari, how have you found downloading the discharge information on Pharm Outcomes?
I think at the moment it's pretty straightforward. We log on about twice a day. see at the top if there's any updates. There's a TCAM. We'll click on that, accept the referral, print it out, and leave it for the pharmacist's attention.
And has it increased your workload significantly, or would you say it's part and parcel of what you do?
I think it's part and parcel of what we do. It was initially, just getting into the routine of doing it, and now it's just become normal. Yeah.
And what about things like completing referrals, accepting referrals and stuff? Have you had any problems navigating pharma outcomes?
No, I think once I went through it with the pharmacist, once it was fine. It's pretty straightforward at the moment, yeah.
And have you seen any benefits to patients when we receive the discharge information?
Yeah, I think the turnaround is so much quicker. Pharmacist is able to go through the discharge letter. We're not chasing it up like we normally are. We've got all the parts of it. Nothing's missing. It's pretty straightforward. Yeah.
Hi Sheetal, so I'm going to just ask you a couple of questions around pharma outcomes and the transfer of care work. So how clear have you found the information that comes through on pharma outcomes?
The information is quite clear from what I've seen. I don't actually need to log on to the pharma outcomes. The dispensers normally print out the information that I need, but it's very clear, it's very easy to access, and it's something that I think we've been waiting for and needed for quite some time.
So as a practitioner, what benefits do you see?
Benefits are huge. Patient care after being discharged from hospital would be a lot better, in the sense that we have more efficient communication systems between the GPs and ourselves. There was a lot of guesswork happening before, and that would be resolved now as a result of this. Patients' representatives often have a lot of questions. They're very apprehensive when their loved ones are discharged from hospital, and we often don't have the information at hand. And that's when we have to go and speak to doctors and their receptionists at the surgery, and this has reduced delays when we needed answers and improved communication, which is more efficient now.
Okay. Would you recommend this to other pharmacies that
Absolutely, without a doubt. It will just provide a more holistic approach to patient-centred care in the future, and it's part of the vision that primary care networks want to function as, so yes.
Excellent. Thank you very much for your time.
Thank you.
So I'm going to talk to you about the evidence-based drivers and the patient experience around transfer of care. I work for the West Midlands Academic Health Science Network, and there are actually 15 AHSNs nationally, and the other 14 are already ahead of the West Midlands AHSN with implementing transfer of care. So essentially, it's around 30% of hospitals outside the West Midlands already have transfer of care in place. So there's already quite a wealth of experience about the benefits to both patients and trusts for TCAM. So initially, the most significant study that we had was from Newcastle upon Tyne. So they were the first people to actually link with farm outcomes. So they linked through a web-based connection, and they actually did a fantastic study that they published in the BMJ that actually compared those patients who had a referral and were followed up by a community pharmacist, as opposed to those that were referred and weren't followed up by the community pharmacist. So what they saw was actually those patients that had some sort of support for their medicines by the community pharmacist actually had a reduced readmission rate to hospital, and if they were readmitted to hospital, they actually had statistically significant shorter lengths of stay. So that was a really good study which showed great benefits in terms of capacity for trusts and benefits for the CCGs. But after the publication of that study, there was a number of other studies that were done across England Leeds, Cornwall, Cheshire and Merseyside that all had the same results, and there's an enormous amount of grey literature around about transfer of care, but they're all essentially showing the same things, those shorter lengths of stay and reduction in hospital readmissions. So it's kind of not surprising that we actually have a number of toolkits now available from our professional bodies which tell us that we should be doing this. But what's kind of disappointing for the West Midlands is the dates on these toolkits. So 2011, 12, 13, 14, and now here we are at the end of 2019 and we haven't actually implemented this initiative across the West Midlands. So what I wanted to share with you with some of the patients' experiences. So we've talked about some of the benefits to the quality of care with medicines that they receive, and also the reduction in length of stay, which is obviously a benefit for trusts. But we haven't given examples of individual circumstances. So the following case studies are taken from some of my colleagues in the Wessex and North East and North Cumbria AHSNs, where they've actually interviewed patients and said about some of the experiences. So what's going to happen I'm going to show you 3 case studies, and I'm going to take the part of the pharmacist in the case study. So I'm going to essentially produce the narrative that was given from the other AHSNs from the pharmacist's point of view, but then we're also going to show you some narrative of the patients as well. The hospital referral stated that the patient's medicines had been stopped and dabigatran started, and when I followed up this referral I realised that the repeat prescription for warfarin had not been cancelled.
When I was in hospital, the doctor started me on a new blood thinner. It wasn't until I received a phone call from my community pharmacist that I realised I should have stopped my warfarin. It was really lucky that we caught it in time, as I was just about to order more and the pharmacist asked me to return the unused tablets back to her.
The hospital referral stated that the patient was an insulin-dependent diabetic who had experienced fluctuations in blood glucose levels whilst in hospital. They suggested I followed up the patient on discharge to check that this had settled down.
The pharmacist phoned me and asked me about my blood glucose levels. I always monitor this quite closely and had noticed that my blood glucose went low, particularly after eating. I had assumed this was because I had been trying to lose weight by eating smaller meals, and so I was putting extra sugar in my drinks to bring this back up. But the pharmacist pointed out that my insulin dose was probably too high and suggested I make an appointment with my GP. My blood glucose control is much better now.
The hospital referral stated that a new medicine had been started and the amitriptyline dose had been reduced. When I called the patient, I was concerned to learn that they were not taking their amitriptyline as prescribed.
I take 12 different tablets each day and really thought I knew what I was doing. When I was in hospital, I was told they were going to increase my painkillers, so I'd been taking 3 instead of 2. It wasn't until I had a phone call from my own chemist that I realised I've actually got 13 tablets now and should have only been taking 1 of the painkillers and not 3. I don't know what I'd have done without my pharmacist, as there were a number of other changes to my medicines I'd missed.
Hello, my name's Michelle Haddock. I'm Clinical Pharmacy Manager at Russell's Hall Hospital in Dudley. I've been responsible for implementing TCAM in our hospital. We've had to do quite a bit of work behind the scenes to get TCAM up and running. I think we started by discussing the service with senior managers within the organisation to get approval and sign off. We've had to think about the IT requirements of implementing TCAM and work really closely with our digital department around the choice of solution within Pharm Outcomes, and also how we're going to access the web-based system when we go live. We have also had to think about all the information governance requirements. Our trust requirements included completing a DPIA, a data protection impact assessment. We also had to do an IT vetting protocol. So quite a lot of work went on behind the scenes to make sure that we were sharing our data safely and securely. We've had to think about patient consent because, of course, we need the patient's consent to send a referral to their community pharmacy of choice. So we've had to think about how we're going to gain patient consent, document that, and we've decided to develop a patient information leaflet which we're going to give out to all the patients that we refer through the service. We've also had to think about the staff that are going to be involved with actually making these referrals happen, thinking about the workflow involved, thinking about the procedures that we'll have to implement. So we've had to write an SOP, as you would expect. We've had to think about the staff that are going to be involved in making these referrals, and then we've had to think about how we're going to deliver the appropriate training. This reflects the patient cohorts and numbers of referrals that we're going to make across our STP in the Black Country and West Birmingham area. Russell's Hall Hospital is here in Dudley, and we're going to be focusing on patients with respiratory disease, renal patients, and our patients in acute medicine. We anticipate about 6 referrals a day, which we think will actually materialise in about 2 referrals in community pharmacies per month. The data here reflects the types of patient cohorts and the referrals that are going to be made by other centres across the STP. The following slides reflect patient cohorts and referral or anticipated referral numbers in other areas across the West Midlands, so that you can see the types of patients that will be benefiting from TCAM in the initial phases. So a little bit more detail about the types of patients we're going to refer. It could be patients on compliance aids. That it's very useful to be able to inform local community pharmacies whether or not a patient has been admitted to hospital, and also when they're going to be discharged, for obvious reasons around minimising the waste of the preparation of unwanted MDS trays. It's also useful to refer those patients who need some extra support with their medicines at discharge, if you're thinking this patient might require an MDS when they get home from hospital. Any patients that experience changes to medicines, you can imagine these are numerous and the changes are often complex. Elderly and frail patients, patients that are suffering from substance misuse, or specialist cohorts, for example, respiratory, cardiology, kidney injury. There are lots of different patient cohorts that we might want to focus on, and the cohorts that individual trusts decide to focus on initially will probably depend on the local population needs and the structure of the clinical pharmacy service within that individual acute providing trust. So what's next for us with TCAM? We still have much work to do to ensure that TCAM is sustainable and we continue to increase the number of patients that can benefit from this service. We want to collaborate across the STP with our colleagues in neighbouring trusts to ensure that we have a standard way of referring patients. This ensures that regardless of the patient footfall when they're discharged from hospital, consistent information is received by community pharmacy colleagues. We want to think about the ongoing funding requirements for TCAM. So we've been lucky to have the AHSN fund the first 12 months of the service, but we need to think about funding beyond this time. We want to think about how we're going to implement farm outcomes with our local EPMA systems, our electronic prescribing systems, and certainly within our STP, the 4 providing trusts will all have different electronic solutions for prescribing. So we will want to think about how we integrate farm outcomes to make those referrals much slicker and more efficient. Clearly, with the fruition of integration, then we will be able to expand the service and more patients will therefore benefit from a referral. We found that the benefits of working on this project as an STP have been immense. We've collaborated really closely with things like agreeing our SOPs, developing our information leaflets for patients, talking to each other about some of the practical issues of actually getting TCAM off the ground in our individual trusts. We found that really helpful. We are absolutely convinced that we will have a more efficient, safer process for flow in the hospital, certainly around things like the requisitioning of compliance aids at discharge, the huge efficiency savings that we've learnt about, that we believe are definitely achievable. We want to understand those much better, and we are certainly looking at some local analysis of the reduction in readmission rates and the reduction in excess bed days, and certainly those conversations are really, there's lots of interested parties in those conversations, as you can imagine. How should you be communicating with us? Well, Pharm Outcomes will tell community pharmacy contractors which clinical pharmacist at the hospital sent the referral. So we envisage that communication between community pharmacy and hospital pharmacy colleagues should be improved with the implementation of TCAM. You'll get to know who we are, we'll get to know who you are, and through that, hopefully we will make the patient journey more seamless, safer, more efficient, and we'll learn a lot more about each other's roles equally.
So I think that you'll see from the previous sessions how important community pharmacy is to delivering this service. I know it's change, and I know there's uncertainty, and I also know that there will be some questions about, so what's in it for community pharmacy? Just please remember, the government is actually expecting community pharmacy to change the way that it operates away from just a primarily supply function into service delivery. This is in the 5-year plan, the new 2024 pharmacy contractual framework. This will come national. I think we've got an opportunity to shape it, to deliver it, to be recognised in delivering improved patient care for all of those risky patients. It will save you time. Just think about the amount of time and effort you spend trying to resolve a patient's new medicines after a hospital discharge with no communication from the trust. This will actually smooth that out, and it will make patient care better. So I think that it is over to you, but actually just don't underestimate the amount of effort that it will take to make this work properly. But the indications and recognition from all the local commissioners and nationally will mean that more work will come our way, which will be funded, but we've got to demonstrate delivery in this arena in the short term to gather the evidence. There will be some times when it doesn't work properly. It really is important that we understand why patients are rejected, and we will collectively work together to resolve what are recurring issues, so that we get the maximum bang for the bucks.